Antibody-drug conjugates are really a newcomer in the field of myeloma, although we know very well that they are rather well established in the field of cancer and hematology in general. And we have antibody-drug conjugates approved in AML, acute myeloid leukemia, in ALL, acute lymphoblastic leukemia, but also in Hodgkin lymphoma. And the good news, we had a couple of years ago the approval of the first antibody-drug conjugate in relapse refractory multiple myeloma, and this is namely Belantamab, which is an antibody-drug conjugate directed against BCMA, the B-cell maturation antigen. And this technology of antibody-drug conjugates is really exciting and fascinating and highly effective, because actually you are combining the antibody feature, which is like the targeted therapy, but also thanks to the linker, you are allowing for a robust cytotoxicity. And indeed, it works very well, and the Belantamab, for instance, is leading to some very interesting results in terms of response rate, but in those patients who actually relapsed and were refractory to IMiDs, to proteasome inhibitors, to other available agents. And obviously, as you may guess, the next step is about combinations and how to combine these antibody-drug conjugates, and also how to move them earlier in the lines of treatments. Of course, as expected, and this is related usually to the linker in an antibody-drug conjugate, you have to deal with some side effects. And for instance, keratopathy is an issue when it comes to Belantamab. However, I think there is a learning curve here, and also there are now studies suggesting that by slightly reducing the dosage, but also maybe allowing for more time between cycles, one is able actually to reduce the incidence, but also the severity of keratopathy. So, in summary, I think antibody-drug conjugate will represent in the future a sort of a new major key family for the management of multiple myeloma.